This presentation aims to address the tendency children have in recovering more quickly and completely than adults with aphasia. In order to do this, we will discuss and answer key objectives such as what is aphasia, what parts of the brain are affected by aphasia, how do different types of aphasia affect linguistic capabilities in both children and adults, and finally, is a full recovery possible? And if so, is age an important factor?
In order to fully comprehend the following discussion, it is essential we first know what is meant by the terms neurolinguistics and aphasia. According to Trask, neurolinguistics is the study of the relation between language and the brain. Until recently, there was no direct way of examining the functioning of a normal, healthy brain. The only way of extracting information was to study the speech of those unfortunate individuals who had suffered brain damage. The commonest results are some kind of disruption of the victim's ability to use language.
Neurolinguistics is concerned with many neural conditions that may impair the comprehension, production, or acquisition of language. The focus of today's discussion draws upon the impairments in language production or comprehension as a result of brain damage, or in other words, aphasia. Barissa's diagram demonstrates the various types of aphasia and how to classify them, depending on the level of fluency, comprehension, and repetition. Due to time constraints, we shall only be discussing the effects of the two main types of aphasia, Broca's and Wernicke's.
Broca's and Wernicke's are two very distinct, very different types of aphasia. Broca's may be categorised through the patient's inability to produce speech, talking in a laboured and hesitant manner, with particularly a loss of grammatical function words, but also the names of people and objects. However, their comprehension remains mainly intact. Despite their inability to construct grammatical sentences, they unusually retain the ability to produce homophonous words. Their articulation is poor, their pronunciation is slurred, and sometimes it is hard to interpret.
In contrast to this, Wernicke's aphasiacs appear to have very rapid and fluent speech, yet noticeably poor comprehension. They have extreme difficulties with finding content words that are relevant and meaningful. Rhythm and intonation is poor. Their pronunciation is fairly normal, and most of the ordinary grammatical structure or syntax is intact. There may be short sequences that make sense in isolation, but these are strung together in a meaningless way and often broken up by nonsense words.
Here we can see the main linguistic regions of the brain. Broca's aphasia is an eponymous condition and therefore occurs in the Broca's area. The Broca's area of the brain is a small patch, not much more than an inch across, of the cerebral cortex. Similarly, Wernicke's aphasia is found in the Wernicke's area. Wernicke's area, slightly larger than the Broca's area, is on the left side of the cerebral cortex in most people. Research has shown that the Broca's area is fairly close to the motor area of the brain, which controls the muscular movement, whilst Wernicke's area lies behind the auditory area, which seems to be responsible for processing input from the ears. All this suggests an obvious organisation of language in the brain.
Since we've already established what Broca's and Wernicke's are, and what traits make them significant to their particular type of aphasia, I'd like to introduce you to a model created by Susan Edwards called the Sentence Processing Model. It explores the 3 stages of sentence production, and from this you can establish the type of aphasia the patient has. The first stage is the message level, which involves semantic and possible pre-semantic activity. It is being able to convey the message you wish. The functional stage is where the lexical items are selected and grammatical roles are linked to them, although they do not yet have their full phonological meaning. The final stage is the positional level, and this is where constituents of the sentence are ordered and function words are inserted.
Mike Caputo.
And Mike, when was your stroke?
I was 7 years ago.
Okay.
And
what did you used to do?
Worked.
This brief case study puts into perspective the general traits and patterns found within Broca's aphasia. Mike had a stroke 7 years before the video was filmed in 2010. From it, you can notice that his comprehension is intact, but his speech is somewhat effortful. From this short extract, you can instantly see that Mike and many others with Broca's struggle at the functional stage of sentence production because they can communicate lexical words but function words, such as prepositions and articles, are often omitted. To have accurate representativeness of the types of aphasia we are looking at, here is Wernicke's aphasia patient Byron. Byron had a stroke in 2010, and the following video shows him 5 years on from this. In the first 6 months of Byron's aphasia, he only used a mixture of nonsense words to communicate and had 0% comprehension of what was being said to him. But in his 5 years of recovering, it has risen to 60% comprehension.
Hi Byron, how are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We steam for the water over here at the moment. Talk with the people over them over there. They're diving for them at the moment. They'll save in the moment. He'll water very soon. For him. With luck. For him.
So we're on a cruise and we're about to
We
get to
will
New
short
York.
right here and they'll save their hands right there. With them.
And what were we just doing with the iPad?
Right at the moment, they don't show a darn thing.
The iPad that we were doing.
It is evident that Byron struggles immediately at the message level, even 5 years on from when his stroke happened. The message level is what is being expressed, and Byron, along with other Wernicke's patients, are known to substitute lexicon they are unable to locate with either nonsense words or other unrelated words. In the video, we can see he replies, "At the moment, it's not doing a darn thing," in answer to the question, "What did we just do with the iPad?" And this is a potential sign of his increase of comprehension because he has an idea of what she means, but he is unable to explain activities he completed in the immediate past, suggesting he is still not completely recovered. These extracts were used in order to show the most common form of Broca's and Wernicke's aphasia in adults. We used them to show these perspectives and how adults recover so we could compare them to how children's recoveries are similar or differ from these. Adults with aphasia never 100% recover, irrespective of the type of aphasia. In Code's Characteristics of Aphasia, he explains that adult aphasia patients often recover to anomia. Anomia literally translates to without names or nouns. Therefore, even though their grammatical words and comprehension improves, they will continue to have issues with lexical and semantic processing required to form sentences.
We now turn our focus to aphasia within children. Acquired childhood aphasia may be defined as the language deficits following brain lesions after the acquisition of the first words and sentences. This generally applies to the child patients after 2 years old. In children, it has been reported that the functional plasticity of the brain is greater than in adults, and therefore the outcome of acquired aphasia is thought to be better also. However, in the last 15 years, a more dynamic view of the neural plasticity related to language development has emerged, particularly with regards to how age at insult and stage of language acquisition impact the outcome in acquired childhood aphasia. Studies show that brain injuries during these critical periods may cause more significant and severe outcomes. This means that an immature central nervous system at the time of insult does not necessarily lead to a more favourable outcome. The following case studies demonstrate how 2 children deviate from typical aphasiac patients. The first child we look at is an Italian boy, referred to as GS. He acquired non-fluent aphasia as a result of brain damage at 3 years old. Like most Broca's aphasiacs, his comprehension remained intact, but his fluency, amongst other things, was severely impaired. What is unusual about this study is that his recovery process was long and drawn out, and even after 20 years, he is still suffering the ramifications of his traumatic brain injury. This challenges the consensus that children have speedy, more complete recoveries than adult patients of the same language deficit. The study compared his progress to his twin brother, GP, as this was thought to demonstrate best how GS ought to have been performing. Over the course of 20 years, the patient was videoed 7 times. His progress appeared to be painfully slow, and it's thought that this might be due to the fact that children who suffered a lesion on the left temporal lobe and were aged somewhere between 10 and 44 months show significantly greater delay in expressive vocabulary and grammar. The study found that at 3 years and 10 months, his language production showed a higher than normal proportion of morphologically incomplete utterances to both his twin and a typically developing child. Compared to results at 10 years and 8 months, where his conversational skills were still severely impaired, Even at 24 years, GS's language and literacy performances were still impaired. This discontinuous trajectory of recovery would suggest that the notion of the earlier the better is not necessarily correct.
The graph clearly displays GS's mean length of utterances having a solid increase, typical of standard child language acquisition. However, the sharp increase in mean length utterances we see between 7 years and 11 months and 10 years and 8 months is atypical. In a typically developing child, this burst in vocabulary is between the ages of 2 to 4 years old. We also see how various types of utterances, such as one word, morphologically complete and incomplete, simple and complex sentences, fluctuate with no real progression or correlation.
This study contrasts significantly with the following patient, a 9-year-old Japanese boy who acquired Wernicke's aphasia after a traffic accident. His speech was fluent and his repetition was well preserved, but comprehension of spoken language was severely impaired. When he was requested to write familiar words into kanji letters, he replied, "What is kanji?" though he had no difficulty in copying kanji letters. After 7 months of regular speech therapy, he was steadily reintroduced to school again. 2 years later, he had fully recovered and qualified to enter a normal junior school. Full comprehensive recovery is atypical in adult aphasiacs. The patient's language ability was assessed 4 times by the standard language test of aphasia. During this period, the patient showed a substantial improvement of language, unlike many adult fluent aphasiacs who made little recovery, if any. This type of recovery supports Lenenberg's theory that aphasia acquired before 10 years of age usually recovers completely and rapidly. This test showed that at 2 months after TBI, auditory comprehension and visual comprehension were both severely impaired. His performance was not even perfect for recognition of words. At 16 months after TBI, in receptive language, visual comprehension has showed further improvement, following that of auditory comprehension. In speech, there were simultaneous improvements of oral reading of kana and oral reading of sentences. Kojima notes that these recovery patterns are not usual in adult aphasia.
The MRI scan was obtained at 3 months after the injury. As established previously, the Wernicke's area is located in the parietal temporal junction of the brain. These slices reinforce the notion of an organisation of language in the brain. What's interesting is that although it shows clear damage to the area of the brain associated with language comprehension, the patient's comprehension was far more retrievable than an adult's.
From the 2 given case studies, it may be deduced that child aphasiacs do not perform as successfully or typically as initially predicted. Though there is a clear organisation of language within the brain, this does not necessarily mean that the affected areas will perform the way they commonly would. We see this in the Japanese patient, wherein his comprehension was atypically recovered in rapid time also. We see this in the Italian patient, that age does indeed impact recovery, but not in the way that was originally thought. It appears that those who acquire aphasia younger suffer for longer.
During our research, we discovered an inaccuracy in our hypothesis because it became evident that children did not necessarily recover better or quicker than adults with aphasia. We were able to deduce that recovery depended upon age and their stage in language acquisition. Those who have already acquired language recover quicker than those who have not. We also discovered that higher plasticity does not necessarily equate to a rapid and sufficient recovery in terms of aphasia.
We have provided a list of references cited within our discussion and additional further reading if you so wish to extend your knowledge of the topic. This concludes the end of the presentation, and we'd now like to know if you have any further questions. Thank you!